Care of the Aging Adult, Unit 4, Part 2. This is Martha Olson, Iowa Lakes Community College. Objective 35 is looking at developing a plan to prevent falls and injuries utilizing non-restraint interventions. Ideas for preventing falls that you've seen in clinical, at the nursing home, in a person's home, all need to be thought of. When we think about make sure they have enough lighting, no scatter rugs, handrails are in appropriate places, that is mandated in a facility, long-term care facilities. The state comes in and mandates where and how handrails are. But in the home, you may recommend that it gets installed to help that person get around their home. Scheduled toileting to prevent incontinence, even things such as gait belt, reorient them. Don't use sleeping pills or sleeping medications because they all increase the risk for falls, and we want to do everything we can to prevent a fall because especially with the elderly, any fall can relate into a broken bone due to osteoporosis. Restraints to use or not to use, they should never be used as a punishment or a convenience for the caregiver. We only use them when we absolutely have to. Restraints are used in surgery. That's the only way we keep the people on the cot during surgery. Following surgery, when movement is not advisable, sometimes they have to be used then. What is not considered a restraint is things like SCDs, total knee replacement when they have their knee in the immobilizer. Some of those things are not considered a restraint because they are a medical device to help them, but they can limit mobility and needs to be looked at for safety. Other things we can do instead of a restraint, put them close to the nurse's station, make sure that we have the bed alarm, address their pain. You know, many times they're climbing out of bed or trying to get up because they're uncomfortable. Play some soothing music. You know, try to work with their ADLs. In 1987, Oprah declared that the use of restraints has to be very limited, and the use has declined since then. Think about the medications that are known to contribute to the delirium of older adults, and we need to kind of limit those as much as we can so that we don't have older adults that are on medications that cause a lot of confusion. When we look at management of dementia, we need to think about things non-pharmacological as well. Alzheimer's disease is the most common form of dementia. Vascular dementia is also very common with the elderly. Some of the risk factors are age. When our population gets older, the risk for developing dementia is going to also increase. Family history, genetics, any type of head trauma. We're seeing that with some of our football players now, that when they retire they have a lot of memory and cognitive changes. Vascular diseases, the strokes, the atherosclerosis, any infections such as syphilis, and some of the things that can be modified, those risk factors, preventing head injuries, you know, exercising, not smoking, controlling high blood pressure, controlling hyperlipidemia, and also, you know, all of our cholesterol type levels with diet and exercise. There are meds, the statins help decrease some of those, and in the long term can help. As far as non-pharmacological, that reality orientation, frequently remind them, have things like calendars and clocks. You know, it's noon, because many times they'll be confused as to the time of day. Validation therapy is individualized care, trying to restore or maintain their self-worth. And reminiscent therapy is very effective. It's helping them reflecting on the past. Have the family bring a scrapbook that has them with their old farmall tractor and the kids when they were younger. Many times they will remember long-term things and help soothe them. And for one particular Alzheimer's patient I remember caring for quite often in the hospital, his wife had a picture book of their 50th wedding anniversary, and it had all the kids and grandkids, and we would sit at night when he had the sundowning and was more agitated and look at those, and he would tell me everybody in the family and their name and where they worked and what they did. He had a wonderful memory for long-term past things like that. When we look at pain management, obtain that baseline assessment. Are there other things that we can do to identify their pain, the nonverbals, the restlessness, the change in vital signs. When we look at pain signature, what is pain to them, how they react. One person's pain may be very different and cause them to be withdrawn, whereas other patients will get very agitated and very combative when they are in pain. When we look at common pain behaviors that the elderly may demonstrate, body movement, curled up in a ball, muscles are tight when you go to give them a back massage or wash them up, that they're very stiff. When we look at facial expression, are they frowning, or, sad, grimacing, wrinkling to the forehead, closing their eyes? Verbalizations such as moaning, noisy breathing, asking for help. Some of the patterns that we might see, they refuse to eat. When you're in so much pain, eating is not one of the things that becomes a priority. Sleeping pattern changes where they're restless and waking up every half an hour, every hour. And then with the mental status change, crying, tears, more confusion, irritability, distress, unable to soothe or talk with them. Activity intolerance is looking at, like I said, the picture books, old pictures, folding washcloths. Give them a basket with some washcloths and have them fold them and then do it over and over again. When their hands are busy and they're doing things that they're able to do very effectively, it keeps them from wandering, pulling out tubes, picking at things, organizing cards. Just gather some old Christmas cards that you got and have the pictures and the front of the card available. Soothing music. I remember being with students out to the nursing home, and they had the dimmers on the lights, so as evening started coming on and they were trying to get everybody kind of settled down for nighttime, the lights just got dimmer and dimmer every half an hour until they were in kind of that semi-darkness mode to help them relax, and that works very well with children at home. When we look at assistive technology, they are starting to look at building homes now where there is an apartment on the main house for the older parent to live in. It has a separate entrance, but yet they are very accessible to their family. So there is a lot of things that we're seeing. The smart home to increase safety. There's a central control unit, and maybe the daughter that lives in another part of the state can see in there, can know the temperature, all of those types of things. Things like reachers and magnifiers, hearing aids, all of those types of assistive technology are very beneficial to help maintain the activities of daily living. As we look at end-of-life issues, we know that as nurses, we spend more time with patients and their families than any other member of the healthcare team. 80% of the elderly or dying wish to die at home, but actually less than 25% actually get that wish. In hospice, about 75% of them will die at home. When we look at the accumulation of experiences throughout a person's lifetime, that helps to clearly define the way he or she wishes to experience his or her own end of life. What settings do you expect to work in that you'll have end-of-life issues? I would answer for you and probably say all of them. When we think of working in OB, the death of a baby, the death of a mother happens. Working in a prison, they have deaths there. In the clinic, in the ER, it's not just long-term care where you're going to have death and dying issues. We know that death is a very unique experience to every person and their family. And as a nurse with lots of hospice experience in the hospital, personal experience, we know that everybody has that unique experience and has that unique wishes during that time. A big part of my job as a nurse is communicating. Just listening to the family, understanding what they want and how, so they feel like they have some control. Talk about death. It's not as difficult as you would think. Sometimes we have that fear of talking about it, like we'll cause it to happen, but there is easier ways to approach that when you're very comfortable with the death of the person. As related to, the older person that has made that wish is a DNR versus the ER where it's a tragic car accident. It's a very young person, and you know, it comes as a very big shock to the family. If you're not comfortable or not in a position where you're able to work with the family, you know, get your social worker. I work in a Catholic hospital, and we have a nun that's there to help us during those times. To meet their wishes, make sure that you address the no code. If they are a no code, make sure that it's on the chart and they have the bracelet so nobody starts CPR if they would expire during your shift. That durable power of attorney, remember, is the person that can make the choices or make the decisions for them. There is a thing called 5 wishes, and anybody that's in that early stages of death and dying would want to, I recommend it. It's a paper they fill out that says, when I'm dying, these are the things I want. And it's all about very personal things like, you know, I want my family to care for me. I don't want my family to wash me up. Advanced directives, remember, are future medical care. It's a very legal document. It's written in case they can't make decisions on their cares, and make sure if they have like a living will, a durable power of attorney, it's all very clearly on the chart and documented so that there are no questions about what type of care and what they need. To qualify for hospice, they have to have a life expectancy of 6 months or less. It is not just cancer. It's any terminally ill person. It was started in about 1983, I believe, and it is very much an interdisciplinary group. Sometimes the RN is a coordinator of care, but they have social work, they have nursing assistants that come in and do the bath, they have a hospital or a chaplain sometimes, or clergy, and then there's always a hospice doctor that makes at least one visit to the patient on admission into the hospice program to visit with that family. For end of life, some of the symptoms that are noted: to ease respirations, elevating the head of the bed a little bit might ease their difficulty breathing or dyspnea. Opioids often are used to treat that shortness of breath. Excessive secretions, there are medications you can put under the tongue or give IV that help dry up secretions so they don't have that death rattle that we often think about. For the GI, opioids are very constipating, so is there another medication that might work better? Make sure that they are taking a stool softener or a stimulant so that they aren't getting constipated because of the medications for the pain. As far as nutrition, declining appetite is very natural. It's kind of the body's way of shutting down. So we just have to be very careful with nutrition. That, you know, artificial hydration sometimes is what the family wants, and it may be seen by the family as a positive thing that they're, you know, not just pulling the plug or not feeding them, but it can sometimes contribute to that failing body as the GI and as everything is slowing down to keep dumping food or TPN or Gevity into that body. It can contribute to fluid overload. So keep the oral cares, you know, frequent. Give sips of water. All of those things to help keep them comfortable. Keep the lips with some Vaseline or other kind of lubricant so that the lips aren't dry and cracked. But we don't typically give a whole lot of nutrition during that time. When we look at pain, we have a whole unit that we're talked about in Intro to Nursing, and as we look at pain now, we know it's very individualized. We want to make sure that we are giving pain medications in combination with each other that are going to help take care of the type of pain that they have. Maybe it's more of a bone pain, and the Duragesic patch will be more therapeutic. Maybe it's more of a chronic pain, and maybe an NSAID would be more beneficial for them. That fear of addiction is not really a consideration when they're a hospice patient, because our main goal is to keep them under pain control and to make their last days very pleasant and comfortable. There are a combination of things like antidepressants, anticonvulsants that work with these medications and can help with that. In the next unit, we'll finish up talking about the different types of pain and some cultural practices.